Welcome. Today, we're delving into the world of the digestive system to understand a serious condition called gastric varices. We'll explore what they are, what causes them, how they're diagnosed and treated, and what the future holds in managing this condition. Gastric varices are essentially swollen, fragile veins in the lining of your stomach. The most common culprit behind them is portal hypertension. This is an increased pressure within the portal vein, the major vessel carrying blood from the digestive organs to the liver. Conditions like cirrhosis, caused by chronic liver disease like hepatitis or alcohol abuse, are the leading drivers of portal hypertension. Less common causes include splenic vein thrombosis, a blood clot in the vein draining the spleen, and Budd-Chiari syndrome, which blocks the hepatic veins draining the liver. Here's how it works. When the liver is damaged, scar tissue builds up, obstructing blood flow through the portal vein. This obstruction causes blood to back up, increasing pressure within the portal venous system. To bypass the blocked liver, blood seeks alternative routes, often through smaller veins in the stomach and esophagus. These smaller veins weren't designed to handle such high volumes of blood under pressure. They become dilated and tortuous, forming varices. Because these varices are thin, walled, and under high pressure, they're prone to rupture and bleeding, leading to potentially life-threatening gastrointestinal hemorrhage. Gastric varices are primarily associated with liver disease, so their prevalence mirrors the prevalence of conditions that lead to cirrhosis. This includes chronic hepatitis B and C infections, excessive alcohol consumption, and non-alcoholic fatty liver disease, which is becoming increasingly common due to rising rates of obesity and diabetes. The exact number of people affected is difficult to pinpoint, as many individuals with early-stage liver disease are unaware they have it. However, it's estimated that a significant percentage of people with cirrhosis will develop varices at some point in their lives. Often, gastric varices don't cause any symptoms until they rupture. When they do bleed, the primary symptom is hematemesis, vomiting blood. The vomited blood may be bright red or look like coffee grounds, depending on how long it's been in the stomach. Another common symptom is melena, which refers to dark, tarry stools caused by digested blood in the intestines. Large bleeds can lead to hypovolemia, or low blood volume, resulting in symptoms like dizziness, lightheaded weakness, rapid heart rate, and even loss of consciousness. In severe cases, untreated bleeding can be fatal. The gold standard for diagnosing gastric varices is an upper endoscopy. This involves inserting a thin, flexible tube with a camera attached into the esophagus and stomach. The endoscopist can directly visualize the varices, assess their size and appearance, and even take biopsies if necessary. Imaging techniques like CT scans and MRI can also be helpful in assessing the liver and portal venous system, identifying the underlying cause of portal hypertension. Portal pressure measurements, although less common, can be performed during endoscopy or liver biopsy to quantify the severity of portal hypertension. While less commonly used than classifications for esophageal varices, gastric varices are sometimes categorized based on their location and relationship to the esophagogastric junction, the area where the esophagus meets the stomach. One system describes gastroesophageal varices, GOV, which extend from the esophagus into the stomach, and isolated gastric varices, IGV, which are found solely in the stomach. Further sub-classification depends on the extent of the varices and their connection to the splenic or renal vein. The primary goal of treatment is to stop the bleeding and prevent future episodes. Acute bleeding is often managed with endoscopic techniques such as band ligation, where small rubber bands are placed around the varices to cut off their blood supply, or sclerotherapy, where a medication is injected into the varices to cause them to shrink. Transjugular intrahepatic portosystemic shunt, or TEPS, is a procedure where a shunt is created within liver to redirect blood flow and reduce portal pressure. Medications like beta blockers and somatostatin analogs can also help reduce portal pressure and the risk of bleeding. In some cases, surgical interventions like splenectomy or liver transplantation may be necessary. Prevention is key, and it starts with managing the underlying liver disease. This includes avoiding alcohol, treating hepatitis infections, managing non-alcoholic fatty liver disease through diet and exercise, and adhering to medications prescribed by your doctor. Regular monitoring with endoscopy is also important for individuals with cirrhosis to detect and treat varices before they bleed. For those with known varices, beta blockers can significantly reduce the risk of bleeding. The prognosis for individuals with gastric varices depends heavily on the severity of the underlying liver disease and the effectiveness of treatment. Bleeding from gastric varices can be life-threatening, but with prompt diagnosis and appropriate management, the risk can be significantly reduced. Ongoing research focuses on developing new and improved endoscopic techniques, medications, and interventional procedures to further reduce the risk of bleeding and improve outcomes for patients with this condition. Additionally, advancements in liver transplantation have greatly improved the survival rates and quality of life for individuals with end-stage liver disease and associated varices.